In progress.
Hello, everyone, and welcome to our March Community of Practice workshop. So glad to have you here. As you're coming into the room, if you would please drop into the chat who you are, where you're joining from, and what is your favorite thing about spring. If you will drop into the chat who you are, where you're joining from, and what is your favorite thing about spring. We are going to go ahead and get started because we have a fun and exciting and full workshop today. We are recording. If you have not already, I'm getting a little bit of feedback. If you have not already subscribed to our YouTube channel, we invite you to do so, as well as we will have live transcription available. You can go ahead and hit the closed caption is available as well. So many of you are already familiar with us, but in case you are new and you are not familiar with PFCC Partners, this is who we are and what we're all about. Our mission is to center the inclusive human experience of health, and we're looking to do that by being a catalyst for system transformation. You see our vision and our values, which include equity, inclusion, diversity, collaboration, and being solution focused. We all know that healthcare is complex. It's a very difficult system to navigate, and it's even more difficult to change the system. So, we have created a space, PFCC Partners has created a space within the system for patients and family caregivers to drive improvements. One of the ways that we do this is through our PFA network. The PFA network was designed by patients and family partners for patient and family partners. It fills the space with impactful people, stories, and insights. So it brings into that nothing about us without us. So I'm so excited about our topic today and this new framework that we will be going through, looking at ACT, or the Advisory Council's Transformed Framework, initiating authentic partnerships with patient and family partners. So I have the wonderful pleasure of introducing our CEO and founder, Libby Hoy, as well as Lindsay Galley, our VP of Programs. Lindsay, you want to take it away?
Sure. Thanks so much, Naomi, for that introduction. And hi, everyone. It's so good to see so many familiar faces and some new faces. And I'm loving looking at what you all love about spring in the chat. I think we share some of the same loves for spring, especially the flowers. My personal favorite thing about spring is the longer days or nights. So loving that the sun isn't setting at 4 o'clock right now. But yes, thank you all for being with us today. I'm going to kick us off with a little bit of background, and then I will pass it to Libby, who will outline the Advisory Council's Transformed or ACT framework. We were just talking, and this has been months and months in the work. We've talked to so many people about, their challenges with sustaining advisory councils and what their hopes are for what patient-family engagement can look like within their organizations, which we'll outline through our presentation today. But where this all stemmed from, part of our work is working with health systems, hospitals, other healthcare organizations and stakeholders to support the development of patient-family engagement and utilizing that as a strategy when applied to the work that your healthcare organizations are already doing to improve outcomes for all patients. Through that experience, we have seen our health system partners challenged in the past, especially when it comes to our rural health partners and primary care when implementing patient family engagement or developing a patient family advisory council. There are limited resources to put in the effort to develop and sustain an advisory council in these areas and in other health systems as well. I think we've seen that a lot through the past 5 years with the pandemic. We've also seen that PFACs, Patient Family Advisory Councils, I'm going to say PFACs from here on out, just a little quicker for me. But they frequently fall short of representing the whole patient population served. And we see that because our regular advisory councils are typically meeting once a month, sometimes around lunch in the middle of the day, and there are only a select few individuals from your populations who have the time to take to go in person to those advisory council meetings. We've learned over the past 5 years too that volunteerism is a privilege, and it is a privilege to be able to take that time to go physically to an advisory council meeting in the middle of the day. So we often see that representation falls short. And then PFACs, their impact can really be limited by organizational structures that isolate patient family advisory council activities. So, if an advisory council is structured under patient experience, that's where we're going to see the impact is inpatient experience, which is great, but there's so much more going on within your organization as far as quality goals, safety goals, and other organizational priorities. So wherever that advisory council fits into your organization is where the impact tends to be siloed. And then we see that health systems often struggle to sustain advisory council membership. There tends to be a lot of drop off. Life happens, especially for patients and their family caregivers. Things pull us away from these volunteer positions, and it can be a challenge to, show up regularly to advisory council meetings and make that rather large commitment to be a patient family advisor on, your typical patient family advisory council as the way they're structured now. Another thing that has really pushed us to think differently about advisory councils is on the next slide. So next slide, please. And this is the Patient Safety Structural Measure, or PSSM. In this patient safety structural measure, there are 5 domains all focused on patient safety, but we were most interested, of course, in domain 5, which is around patient family engagement. The domain says that the effective and equitable engagement of patients, families, and caregivers is essential to safer, better care. Hospitals, this is specific to hospitals as well. Hospitals must embed patients, families, and caregivers as co-producers of safety and health through meaningful involvement in safety activities, quality improvement, and oversight. So some of the attestations that come with this domain, you can see on the screen here. We have 3 that are highlighted in dark blue, which are more so focused on hospital operation activities, and then 2 that are highlighted in orange, more so around that bedside caregiving engagement. So the first was our hospital has a patient family advisory council that ensures patient, family, caregiver, and community input to safety related activities, including at board meetings. So really focused on that connection to safety, the patient family advisory council and safety. The other attestation is our PFAC is diverse and representative. The other one, more so on hospital operations, is our hospital incorporates patient and caregiver input about safety events or issues. And the two other attestations that are more for that bedside engagement, we have patients have access to and are encouraged to view their own medical records, and our hospital supports family and or other designated persons presence 24 hours a day as feasible. So when this structural measure came out, it really pushed our thinking to, what is a patient family advisory council? How do we define that? and how can we grow from what we know as a typical patient family advisory council, but be able to meet this safety measure and also meet, some of the challenges that we have seen in the past. So at this point, I am going to pass it to Libby to introduce our very exciting ACT framework. Libby?
Thank you so much for that background, Lindsay. That's really important as we think about kind of the evolution of the ACT framework. And so on the next slide, please. Um, Taking all of that background and thinking about where people were struggling and even beyond the PSSM, but how research teams were struggling to get patient family partners engaged and measure developers and others, we really wanted to kind of, like Lindsay said, push the envelope on our thinking about PFAC. So we started with looking around and seeing how are PFACs defined? Does CMS define PFAC? Does anybody define, and generally it's a generally understood sort of format, but in no place was it actually, a requirement really stated in concrete terms. So we took that opportunity to say, all right, well then maybe we can define what a PFAC really is and what it could might look like, and how it could importantly serve organizations.
No, stop.
Uh, Maybe not for me. Um, okay, so what we did is kind of bubble down all of those things that we learned in terms of people's challenges and our background to a few aims and a few strategies to develop the ACT framework. So firstly, we wanted to increase the diversity of patient family advisors and patient family partners to better represent the community they served. Well, how did we do that? We actually, and you'll hear this all the way through, we actually looked to our own practices with the PFA network. And when we flipped from having recruiting patient family advisors to a council and really opening doors and allowing patient family partners to self-select activities that were relevant for them, we saw the diversity increase. We saw the number of folks engaged because they had many opportunities to select some from. So maybe they couldn't make a once a month commitment, but maybe they could join a 6-week quality improvement team or another activity. So that was an important flip. Secondly, we wanted to reduce the burden on organizations by offering multiple lanes of engagement. Again, not one size fits all, but what works for the organization. So you'll see in a few minutes that we're providing multiple lanes for engagement for health systems to select the ones that meet your needs where your organization is. If you haven't started a PFAC, then don't start with a PFAC. If you have if you have a particular priority, you can just engage straight to that using a multitude of engagement strategies. And then finally, maximizing the impact of the patient family, at patients and families and the councils by directly engaging patient family partners into health system operations. So you'll hear our team frequently talk about patient family engagement isn't additional work, or it shouldn't be additional work. It should be a resource to the work that you're already doing. And so the ACT framework really tries to provide that flexibility to organizations for their patient family partners to inform the work that they're actually doing, not creating additional work. All right, so what did we do to get started? On the next slide, you will see, you'll see our gears. So you see gears all over our logos, and you might have thought they were just cute. They're not just cute, they're also functional. And because we always want to work with health systems, with hospital or ambulatory staff or researchers or whoever that might be, and with our PFA network, our patient family partners, people with lived experience who are dedicated to the role of partnering across the health systems to inform improvement. We always work in that way. We listen first and then we continue to evolve, which means we're never actually done. We're never actually finished. But this is what we're really excited to bring forward and get people to start using it and see how it works. So with gratitude, we have several PFA Network co-design sessions where the PFA Network members joined us to let us know from their experience as PFAC members, sort of how does this resonate with them? It was very interesting. On that first co-design session, we had, I think it was around 20 patient family partners. And even though they were all very experienced patient family partners, only 70% rather said that they were not currently engaged in PFACs as they understood them. So that's all that resource left on the table. And that gave us even more excitement about the flexibility in the ACT framework. We had healthcare staff co-design sessions as well. So who's going to be using it? We want it to work for our patient family advisory program coordinators. We want it to work for the hospital systems. We had a great group from the Los Angeles County Department of Health Services, all of their PFE champions. We had another session with patient family partners from the LA County hub. Our friends at the Indiana Hospital Association staff also looked at it and gave us their feedback based on what their hospitals needed as well. And finally, and importantly, our great friends at Convergence Health. Their staff members continue to look at it with that QI perspective and really how can we meet the needs of healthcare organizations, frontline staff, and our patient family partners. All right, so ta-da, on the next slide, the ACT framework. All right, so I'm going to spend a couple minutes on this slide because this is where we really kind of flip the model. We put the PFAC in the center. The PFAC then becomes almost the administrative function within the organization. So rather than, at its essence, this is a distributed model for PFAC. So a PFAC would, at the organizational level, then have a coordinator, and that person would track activities and evaluate engagement opportunities. They would facilitate recruitment specific to the project or initiative in front of them. That person would work out preparation. Preparation for staff and patient family partners is essential to high impact partner collaborations. But that preparation, that might sound like a lot for this person to do, but that could be a templated piece that could be just modified with each new project. And then finally, coordinates compensation if that's available in your organization. So one of the features of the PFAC then, as I mentioned before, people, patients, family caregivers, community members who are served by your organization, your research project, your whatever you're doing in the healthcare space, they can self-select into the activities that you're coordinating. So again, the coordinator would have oversight on that self-selection process by putting out recruitment notices that are relevant to the exact activity that the patient family partners are going to be engaged in. Sorry, let's see. They would provide communication access for any groups that may need additional support in accessing some of these advisory committees. And I can say, because again, we do it ourselves, with the advent of some of these AI solutions, language access actually becomes a lot easier. And the hospital benefits for that additional diversity in perspectives. All right. And then getting into the actual activities, we have a number of information gathering activities. We have information gathering activities and co-design activities. If you're just starting out, dig into some of those information gathering activities. That's still engagement. That's still PFAC activity. But it gives you a starting point for some of those bigger co-design efforts. So again, the coordinator would help distribute surveys, could be listening sessions, focus groups, interviews. I was always a fan of just hanging out in the waiting rooms and talking to people, at coffee chats, lots of different ways to gather the insights and information from your patient family partners, in addition to the patient experience surveys. But patient family experience surveys often don't give us an opportunity as patients to give you all of the insights, particularly when it comes to quality and safety issues. So using information gathering activities. And then in the upper right, the PFAC would then have more of an impact on patient-family engagement and care. And I think that if PFACs aren't directly impacting the level of engagement and care, then we are really missing an opportunity, right? So, for instance, organizations that are working on culturally responsive care, what does that mean for your community? And how are you going to figure that out if you haven't done any information gathering from the people who need that culturally responsive care, right? So, again, this is giving organizations strategy to gather the information that they need to put in place the processes that they're being asked to put in place. Okay. Similarly, with patient-reported safety events, part of the PSSM, how are you going to do that as an organization? Well, call in some of your patients and families through this distributed model to inform how that program gets set up. Okay, so again, patient-family engagement is a strategy to improve outcomes and design programs. This model gives you the opportunity to do that. So PFAC would also mean a community. You'd then have a community of patient-family partners, not just 12, but hopefully more and more. And so if you have an existing PFAC, this is a place where your existing members can really shine. They can come in and say, hey, this is what we do as a patient-family partner. They can be that peer mentors to new and inviting in. Nobody invites in patient-family partners like other patient-family partners, right? Just like in any other peer group. So a really great opportunity to leverage your existing patient-family partners or start to create a sense of community. Again, we do the same thing in the PFA network. We have quarterly meetings, we do newsletters, we have an online forum, we highlight patient-family partners and sort of what they're doing. We do some capacity building, and a lot of our participation is online, which is a great tactic for inclusion. Inclusion builds diversity. Having an online presence is, or an opportunity rather, is inclusion. And then finally, the co-design activities. And this is a lot what's in the PSSM. And I know that people are stressed by that, but I'm so darn happy about it because I know you as organizations are going to get the benefit of co-designing with your patients and families. You're going to have a whole new resource that you haven't had before. And I know that it looks like it might be, concerning to be transparent. Of course, transparency is concerning. Don't start there. Start with some information gathering and build to that. So this is a pathway to get you to a really high sustainable and high impact patient-family advisory community. So we're switching the C from council to community, PFAC. All right. Let's move on then to the next slide. And I'm going to just call out a few features thinking back to those aims that we wanted to meet. So firstly, PFAC is the infrastructure. For any of you who know PFCC partners, we are all about infrastructure, putting the infrastructure in organizations for sustainable and valuable patient-family engagement. You have to have a foundation. Otherwise, it's just sort of in the space, and it doesn't directly connect to benefit the organization. So PFAC is the infrastructure, leads to greater impact, and it does reduce the burden on the organization because you can modify how many activities you have going, what sort of activities you have going, if you have that infrastructure. Okay. Lanes of engagement, all those different activities, different ways, information gathering activities, co-design activities, lots of different ways to hear from your patients and families. Again, greater impact because it's directly related to your organizational priorities. It also reduces burden because you don't have to sustain a 12-month agenda, but rather you're able to be specific to, again, that direct initiative. All right, and then optional level of efforts. it brings in greater diversity, as we said. So if I don't have the time to make a 12-month commitment to evening meetings, and I choose instead to pop into a sepsis listening session because I've had that experience in your organization, how much more beneficial is that focused interaction going to bring, right? So it increases diversity of the responses that you get and reduces burden on the organization. One thing I wanted to jump back, I knew I had another thought on lanes of engagement. You know how when a lot of patient family advisory councils have an agenda and maybe a quality improvement team comes and tells them about their agenda and the PFEX talks about it, and that information then goes back to the quality improvement committee. That quality improvement committee, where's the translation? Think about that game telephone. Where is the translation of that information? So instead of taking, really removing that layer, it reduces the burden on the organization just to put that voice in the quality improvement committee. So wanted just to make that point of how else it reduces burden. Self-selection is a different way to go, right? People, I think, for a long time have looked for the right patient-family partner. I think at any given time, I was the right patient-family partner and really the wrong one. And most of that was about how I was prepared, what I understood about the engagement opportunity that I had. So, again, offering multiple lanes of engagement offers greater diversity and builds greater impact because you're hearing from the people that have had that experience at your hospital, as opposed to a more generalized group. Okay. That leads to specific preparation. Again, reduces burden on the organization and has greater impact. How many times I've heard from organizations, well, we had a patient family partner, but they were always kind of going off track and kind of really stuck in their story. The more I talk to patient family partners and the more times I've had that experience, it's because I didn't know the context. So, really specifying a focused preparation for a given activity just increases the impact because we're all on the same page. We're all under the same North Star. That reduces burden on staff to not have to go back and rediscuss and try to bring information that isn't valuable back to the organization. And then finally, and hugely, integrate into existing workflow. Obviously, that's going to reduce burden and have a greater impact. So instead of going out to the PFAC, bringing patient family partners into the hospital health system research organization. Look at that org chart and see where you can sprinkle people in. That's a much reduced burden way to get the impact of effective patient family partnership. Okay, so with that, I think I'm turning it over on the next slide, please. Oh, one more. I kept mentioning those lanes of engagement. I love this graphic that Lindsay made. She's so creative that way. There's multiple lanes of engagement, and this list is just a smidge, right? There's many, many more, and that's where I think the creativity of a community like this, having the PFCC Partners community, just adds to this list. But thinking about what would be effective, we're just getting started with this project, and we really don't know where their blocks are to getting their medications. Where is the medication adherence issue coming from? So let's have a survey and just kind of figure that out, get some people's responses. That can build on itself into developing questions for a listening session, or maybe highlighting the primary driver in your community to inform your safety initiative to address that problem. Okay, so lanes of engagement aren't just a single lane. Don't pick just one, but you can build out your strategy, giving you the ultimate flexibility to start where you are. If you already have a patient family advisory council and you're well integrated into the organization, then maybe you want to just move some folks out to the safety committee. Maybe that works for you at this point. Ultimate flexibility through multiple lanes of engagement. All right. Oh, and resource development, I just want to make mention. Under that, you might think about patient education materials. Boy, if you're creating patient education materials, please, please, please include the patients that represent the materials, the population that will need those materials. The insights are incredible. And, in that way, you know that your patient education, you know that your safety initiatives are hitting the mark. Let's take that example from medication adherence. And you have a survey, you find out some things about what the drivers of that issue are. Maybe it's totally different than what you as an organization thought they were. But by having that insight, you're now solving the right problem. That's the biggest efficiency in this model. By getting that information up front, you're certain that you're solving the right problem. So if medication adherence is not just about people deciding to take their medication or not, but actually in your community, that pharmacy doesn't carry that medication, then you're solving the right problem. So that's the biggest efficiency. All right, so on the next slide, how do we decide which lanes of engagement? I know this is super small and I'll send it out as a resource afterwards. But this is basically a decision tree that starts with the scope. Scope is everything because it drives everything underneath it. So having a solid scope for what you're engaging people to, patients and family partners to, whether that's to design a patient safety reporting program, or is that to design research priorities. Whatever the scope is, that's your driver. So that starts at the very top. And then you can ask yourselves these questions. Do we have leadership support in place for that? Do we have existing patient family partners? You can move back and forth across this decision tree. And maybe you do, maybe you don't have it quite yet. So then how does that get you down to, are you at the stage where information gathering would be helpful? Or are you ready to jump into co-design? And maybe you go back and forth a couple of times, and that's okay too. So interconnected approaches ensure representative engagement of your entire patient community. How awesome would that be? So cool. Okay, so I think that was a lot of information, and I hope you guys have questions because we are eager to answer them. But we thought it might be a little bit easier to kind of see it in action if we went through a couple of scenarios. So on the next slide, I'm going to toss it back to Lindsay, and she's going to lead us through a couple of scenarios where we would implement the ACT framework.
Great. Thanks so much, Libby. And I think we also got, a few requests in the registration for, okay, how? What are those first steps we have to take? So wanted to provide a few scenarios to walk through. So let's go through this first scenario. We have General Hospital serves a rural community in Tennessee with a large geographic area. General Hospital convenes a quarterly Patient Family Advisory Council meeting to engage with community members. However, the PFAC's membership does not fully represent the diversity of the community General Hospital serves. The intended outcomes and priorities for convening the advisory council are not well identified internally nor among the advisory council members. General Hospital is focused on developing a process for patients and family caregivers to report safety events in the hospital. They seek to authentically engage patient family partners in developing this process, as well as meet new requirements for patient family engagement practices under the patient safety structural measure. So what we had reviewed before. So what are these steps to engagement? Let's go to the next slide. First and foremost, define scope. I don't think we could say that enough. Get really clear on the scope of your efforts. So from that from this scenario, this hospital scope is to develop a protocol for patients to report safety events. Patients and family caregivers to report safety events. Sorry, I'm just going to my notes so I make sure I get everything in here. And as well as staff to respond to safety events at the hospital. So the scope is all patients and family caregivers that are impacted. So once you have that scope, you can then start to do some of those more informational activities that Libby had described on the lanes of engagement. So one, hosting a survey of the full patient population and staff members to get that 360-degree view, to identify some communication pathways or thoughts on how a protocol for this, how we can put a protocol together. Then you can also gather additional information, go a little bit deeper, and host a listening session to potentially explore outcomes from that survey, or have more broad discussion about, communication pathways and developing, the best way for patients and staff to report on safety events within the hospital. So once we have that information, we take all that in, we have a lot of good information to go off of, we can move forward to planning co-design activities. So the team working on this can draft a protocol based on patient family partners listening session and staff input, and then move forward to convene a work group to refine and test the protocol with staff and patient family partners. One key point that I don't have on the slide, but it's preparing. So Libby had talked about this before, but preparing both staff and patient family partners for that collaboration to work together on these co-design activities. It's really essential for patient family partners too to have a good understanding of, how changes are made within your hospital. What resources does your hospital have to implement protocols like this? And for staff, what's the best way to work collaboratively with patient family partners? That preparation is key. And for this scenario, General Hospital, they can include some of their current Patient Family Advisory Council members and also participants from their more broader listening session as well. Then after that, doing those co-design activities, gathering additional information about implementing and developing this protocol, doing an evaluation and evaluating both staff and patient family partners, again, getting that 360-degree view of this process, the process for being engaged and developing this protocol collaboratively. That gives you some really great insight that you can then go back and use to improve processes. And then, of course, tracking everything. We use a tool called Smartsheet where we track literally everything, every engagement opportunity that we have. We track, responses to surveys, outcomes from listening sessions, and so whatever your health system or team uses to be able to track everything, it's essential to keep all of that up to date so you can use that for annual reporting, or just communicating things that you're really excited about that happen throughout this process of co-designing. And so all of this would happen from that PFAC, that administrative arm, the recruitment, the sharing the survey with the community, the recruiting for the listening session or opening that listening session to the community and allowing people to self-select in to that listening session, and so on and so forth. So that is scenario one. And then we'll go to our next scenario on the next slide. Okay, so La Clinica is a primary care practice serving Phoenix, Arizona, which is a large urban area. La Clinica has been directed by the plan to improve outcomes for the Latino-Latina population living with diabetes through better self-management. The measure of this improvement outcome is a drop in the number of emergency room visits for diabetes. La Clinica has tried several strategies, such as hosting diabetes learning modules, providing nutritional guidance, and encouraging exercise within every visit, but they have had little success in moving the number of diabetes-related emergency room visits. La Clinica does not have a PFAC, and they are hesitant to engage their patients in this project for fear of being perceived of not being an effective primary care practice by the community. So let's walk through the steps for this scenario on the next slide. Guess what that first step is? Define scope. We can't get anywhere unless we have a really clear scope that focuses us on our priorities. So La Clinica's scope is patients who are treated for diabetes at La Clinica. So knowing that they don't have a patient family advisory council and there is some fear of, community perception of their primary care practice, they start with informational activities. So one is a survey that can be distributed to patients who have diabetes who, go to their clinic. And you can start to identify blocks to help meet their measure. And then also, at the same time, you have that survey out, or even utilize the survey to invite participants to join a listening session to, again, dive deeper into those blocks. And I think this is something that gets overlooked sometimes is hosting a survey is actually a really great way to then start to build your community of patient family partners. If a patient is providing you information through a survey, they might be inclined to maybe take that next step and participate in a listening session and, dive a little bit deeper into what some of those blocks are for going to the emergency room or, managing their diabetes. So utilizing some of those informational activities to then also move into planning co-design activities. So one, of course, like I talked about in the first scenario, part of that planning of the co-design activity is preparing staff for engaging with patient family partners. And a lot of that too comes with going back to your scope, reminding people of what our scope is for, this co-design activity. And then also the patient family partners. So doing some recruiting through those listening sessions and that survey to identify participants to join. Maybe it's a half day co-design session at the clinic and preparing them prior to with context and aims and a goal for this co-design activity, then really articulating that long-term vision of what this clinic is looking to improve. And so, of course, after that comes evaluation of staff and patient family partners. Again, that 360-degree view, it gives you really great information from both sides of that collaboration. And again, tracking everything, tracking, the number of patient family partners engaged and tracking what had been shared. And also what was, I think, mentioned in the chat too is okay, so after this co-design activity, maybe a new procedure is implemented. Give it 6 months and then, look back and see, wow, what we had worked together on previously, look at all of these improved outcomes that we have now and articulating that back to the participants of, those informational gathering exercises and co-design activities. That communication loop is essential as well. All right, I'm going to stop there and pass it back to Libby to talk about some non-negotiables in the ACT framework and then any other thoughts on these two scenarios.
No, I got it. Mute button. Got it. All right. So as we're talking to people, and particularly staff from rural health and primary care, we're learning all of these barriers, and there are just some things that we can't do anything about. It is going to require effort to develop a patient family engagement program. Having a flexible framework is intended to reduce that burden and increase that impact. So, but it is still, you can't remove the fact that it is going to require some effort, some dedicated staff time towards these managing these activities. And Elizabeth, I did see your question in the chat, and I think Brittany's presentation will answer your question, but if not, we'll definitely get back to that. Clarifying the scope of your engagement reduces so much burden. If you can really focus in on what is it you're trying to achieve and then bring people into that vision, it is so much easier than trying to explain and explain and explain over and over. And as Lindsay and I both said, scope drives everything. So your scope drives your recruitment for that relevant lived experience. It drives your preparation for that relevant context for them to engage. It drives your evaluation. So really, if you can get clear on the scope, it makes everything downstream so much easier. Preparing patient family partners and staff for engagement is essential. It's critical to the impact of collaboration. When everybody comes understanding what that scope is and how they line up under your North Star, it's such a more productive place. So when we do that preparation outside the actual activity, then the actual activity is super productive. But coming in, and I just talked to a hospital who was struggling with this, coming in and then trying to explain to the patient family partner why they were doing this project, why that was important, like all of that, let's get that out of the way outside the meeting. So the meeting is super productive because it's very focused. It's essential to connect the engagement priorities of the organization or team. Many times we get asked, what should be on a PFAC agenda? When I get asked that question, it's a signal to me that the PFAC activities are not closely enough aligned with what's important to the organization. So that's where we get that siloed effect and not high value, sustainable patient family engagement. If your entire organization is focused on meeting the PSSM, then engage patients and families into those activities specifically. It is such a more meaningful and high impact collaboration. And the role of the staff coordinator, the person who is really doing driving the administrative arm, being the patient family advisory community. You're going to need one, probably not going to need a full-time person. And Brittany will share the amount of time she spends in the PFA network to kind of illuminate that. But it depends on the size of your program. Maybe your program is very small right now, so maybe you only need a few hours a month. And I know I said that like you're not all stretched, which I know you are, but it's going to take effort. It's going to take some staff time. How much staff time is relevant to the amount of activity within your PFAC, your patient family advisory community. What fits for your hospital? Doesn't mean, I'm just picking out names on a screen. Doesn't mean that Lori's program isn't going to take, 10 hours, but Rhonda's program only takes 2 hours because that's what that hospital needs, right? We're trying to match need with impact. So a couple of things just to keep in mind as you move forward. And I'm going to turn it over to Britt on the next slide.
Okay, wonderful. Thank you. And hello, everyone. So yes, talking about the PFA network. So this is our wonderful community of patient and family partners across the entire country. And really the PFA network is the ACT framework in action. It really is. Everything that we have talked about today, you can see and feel through the PFA network. So you can see on the screen that we have these different functions of the PFA network: skills development, community, and engagement opportunities. And so these are all very important and interconnected efforts that really help to make that impact. So we apply the ACT framework definitely in the PFA network. This is a vast community, again, of over 1,100 people, and we are really being mindful of ways that we can function to support our healthcare partners as well as our patient family partners through things such as community building and the engagement opportunities, lots of attention to preparation. That is one of the things that you've heard already, but is incredibly important because the preparation just helps for everything to go a lot smoother. So that will take yes, effort. That will take communication. That takes a lot of transparency, talking back and forth sometimes as that administrative arm. So I will connect with both the healthcare team, I'll connect with our patient family partners, and really work to be assertive and attentive to the needs of both sides for that deeper impact. And then definitely evaluating and checking through, reading through your evaluations and thinking of ideas and ways that we can learn and ways that we can continue to keep doing what's working well. So I hope that continuing on and hearing from you all, we'll be able to hear some of your ideas. But I just wanted to share how it's really great to utilize the ACT framework in action in the PFA network. And on the next slide, so for us, we have over 500 unique voices engaged across the year. And so these are some of the highlights, but one of the other things that I really wanted to lift up from this particular slide, aside from all of the wonderful voices, as well as the stipends that we've been able to pay out, which is over $40,000 in stipends to patients and families and people with lived experience, which is incredibly meaningful. But this last piece that you can see, so 93% of PFA network members who participated in an engagement opportunity felt that their participation was valued. And so this is a very important figure because this shows that through the diversity of offerings that we have, not just one way that we're sharing engagement opportunities or one type of engagement opportunity, but folks are able to self-select what is meaningful for them, what they are able to do. If there's a stipend, if there isn't a stipend, is it virtual? Is it in person? There are all kinds of different ways that our patient family partners can self-select, and then they're able to feel valued in that engagement opportunity. And again, on my end, administratively, I'm working on that preparation piece, making sure that our patient family partners feel comfortable once they get to that engagement opportunity. Everyone does a great job when you feel like you are prepared for what you're showing up to. So that is incredibly important. And then again, providing that infrastructure and keeping up the community feel. We'll talk about it. We talk about different engagement opportunities on our events together as a PFA network. And they're really, really meaningful, and patient family partners are able to talk with each other about what they're into, what they're participating in, and how it's going. And then on the next slide, just wanted to share that in 2024 and so far in 2025, there have been over 40 engagement opportunities, and would love to lift up and highlight that 100% of patient family partners would recommend the PFA network, and 100% of staff would engage a PFA network member again. So you can't get much better than that. And so it's really wonderful, again, to be able to connect with several of you, familiar names on the call, hopefully more, and all of our patient family partners. So thank you all so much for letting me talk to you a little bit about the PFA network. Reach out if you have any questions, and hope that we can work together, or that you are learning a lot more about how advisory councils can be transformed through the ACT framework.
Thanks so much, Brittany. I'm pushing all the buttons and not the right ones. Thank you, Brittany, Libby, and Lindsay, for that robust and in-depth information about the Advisory Council Transformed framework. Want to open it up to questions and answers. I'm going to stop sharing my screen so I can see you all. I'll stop sharing for a moment. So I see Nadine's hand. Nadine, you want to come off mute?
Yes, thanks for taking my question. For a long time, just like when I'm in a new group, like a safety group or something, a spin-off of PFAC, it's not a spin-off, but I mean, it was a launching pad for me to go into something else more specific. As much of a loudmouth as I am, there were 4 months where I didn't say a word because I didn't want to say something that was arbitrary or not valuable. So there's always that. But there's a reason why I prefaced it with that. I don't remember. But one big overarching thing that I don't understand why people don't embrace nationwide, worldwide, is the fifth pier you put on, fifth bucket you had on one of your screens, and which was resources. Now, resources are so valuable, but they're so boring. And unless there's a lot of graphics on them, my first love, um, it's not even enticing to read, but it's such valuable information. People spend so much time to be concise and bring forth good information. It's only going to better their care and outcome and not have to be readmitted. So why isn't that read aloud button? Obviously, I'm not talking about paper copies. Why, in the digital world, why isn't that read aloud button more prominent or encouraged to use? So easy to sit there and listen again, rewind, grasp what they're saying than just reading. That's my question.
Thanks, Nadine. I appreciate that. I think, you as a patient family partner are bringing in your experience and another great idea and another resource. So, yeah, I think that's awesome. And yes, accessibility is important, as there's so much we wanted to share with you today, and it's so hard to pack it all in. But we have a communication access plan that includes things like how can we make it easier for people to participate. Again, the more inclusive we can be, the more diverse you're going to end up.
Thank you.
Thank you, Nadine. One of the questions that came in during registration was about compensation principles and models. Can you share a little bit about that?
Yeah, such a great question, and I know it's a tough one for a lot of hospitals and health systems to come up with compensation. But as Lindsay mentioned, volunteerism in and of itself is a privilege, and so you end up with a lot of PFAC members that look a lot like me. And when we really need to hear from underrepresented organizations, so compensation becomes an important lever in your desire to reach more diversity. With that said, I can share that our framework is basically $50 an hour, depending on what the participation is. In general, most of the people who submit a request to the PFA network are generally around that same sort of area, some a little more, some a little less. But think of compensation too in terms of what your patient and family population might need to participate. So maybe it's not a $50 gift card. Maybe what they need are, is an Uber ride or some other form that would break down. So I think the biggest key I would say is compensation breaks down barriers to participation. So think about what the barriers to participating in this are for your patients and families, and think about creative compensation that can meet those needs.
And I also just wanted to raise up, we had a really great workshop last year with our partners at Los Angeles County Department of Health Services, who have developed a very comprehensive compensation policy for their facility patient family advisory councils, which I think there's about 11 patient family advisory councils, and engagement in other projects and topics and teams through their patient family partnership hub. They've really applied the ACT framework without having a name for it over the past few years. So we can share that and follow up as well, their workshop.
Yes, absolutely. I would encourage you because they were very creative. They went to the local board of supervisors to get funding for it. So they didn't have the money, but the local board of supervisors did. And or maybe your, municipal government or a church in town, whatever it might be. Be creative. It doesn't mean it has to come out of your budget. And then, Elizabeth, I would love for you to clarify that question because I'm not picking up what you're putting down.
Well, so can you hear me all?
Yes.
Okay,
Yes.
I'm on a headset. I normally am not. So,
Right.
one of the struggles that I have in general is just the conflict of providing services, engaging families, and the $75 restrictions that come along in a hospital around inducements. And so whether, engage, how do we just divide this work? I'm PFCC all the way, right? I totally get PFACs. I've been in it for over 15 years, but inducement and compensation with that degree of clarity that we're not potentially in inducing people to come to our hospitals by engaging in this way.
It's a great question, Elizabeth, and I've had a few conversations with CMS staff about this item, and I think that we're going to continue to need to be creative when we think about compensation. But we're also going to need to keep talking about the value that engaging patient and family partners from diverse backgrounds brings. And again, thinking about compensation solely as a method to removing barriers to participation. And when we can demonstrate as a large community that the PFA network now is so much more diverse than it was prior to compensation. When we can start to build that case, I think we can start to hedge those policies a bit. It's a great question.
Very good question. And I know we're right at time or over time. Sorry, Naomi. I just wanted to address Linda's question in the chat if we could. If you have to jump off, please do. We won't be offended. I just wanted to raise it around measuring ROI and impact of engagement. So I know I have some resources, Linda, that I can follow up with you, but Libby wanted to see if there was anything else in response to Linda.
Yeah, I think that's always the question, isn't it? And as Stephen on our team so often articulates, the health system wasn't set up to demonstrate a financial ROI on engaging patients and families. It's just not. That's why it's so hard. But I will share a paper written by the HCP LAN Health Equity Action Team on the social return on investment. And I think that does demonstrate a drive, maybe not as much towards a monetary value, but it certainly points to a community health value of engagement.
Thank you all. And I'm off camera because I'm a little bit under the weather, but it's all good. Libby, I just wanted to give you a heads up too. I've given your all's organization and your name specifically in this regard to a national organization. I'm on their board, and this is something they are pursuing, actively pursuing is research, and then they hope to develop some other kind of a tool that can go into use by others for that very measurement. So thank you. But
Awesome.
anything you can send is wonderful. And then I'll give you more information in an email later.
Awesome. Thank you, Linda. All right, Naomi, you've been waiting patiently.
Wonderful. Thank you all. I know some have had to drop off. We will send the recording. Wanted to let you know that registration is now open for Putting Care at the Center Conference 2025. It'll be happening in Portland, Oregon. If you were wowed about today, the ACT framework, and have more questions, want more information for implementation, please register for the pre-conference. We will be doing a pre-conference session at the conference ahead of time, so you can go ahead and register for that now. Come and join us and get all your other questions answered, as well as put a plan into practice with us. And then last but not least, thank you all again for joining us. This is the last Friday of March. How have we gotten here already? If you haven't already, join our YouTube channel. You can find us on Instagram and stay up to date on LinkedIn. We will see you next month, April 25th. Have a wonderful, safe weekend, everyone. Thanks for being here.
Thank you so long.
Everyone.
Thanks,
Bye.
everyone. Have a great weekend.
Bye.
Happy Friday.
Thank you.